Ms Young.
My lady, the next witness is Professor Vic Rayner.
I do solemnly,
I do solemnly,
sincerely and truly
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Please sit down.
Swapping roles now.
Professor Rayner, your full name, please.
Victoria Rayner.
Thank you. And you are the Chief Executive Officer of the National Care Forum.
Yep.
You've been in that role since 2016.
I have, yeah.
And is it correct that the National Care Forum is a representative body for not-for-profit care and support organisations?
Yes.
Primarily operating in England, although some of them also do operate in the devolved nations?
Yes.
And is it right that therefore your focus is primarily in England, and that's what your statement and your evidence today will cover?
Yes.
Does the National Care Forum currently represent 176 provider organisations?
Yes.
And they collectively provide care and support to over 260,000 adults.
Yes.
They operate over 8,000 services,
Yep.
provide more than 56,000 care home places, and employ over 145,000 staff.
Yes.
During the pandemic, as at July 2020, is it right that your membership totalled 120 members?
Yes.
So there's been an increase of almost 50% since the pandemic. To what extent, if at all, do you think that that's attributable to the raised profile and visibility of the National Care Forum during the pandemic?
Possibly, yes. I mean, we spent a lot of time in the pandemic supporting organisations, and we were very clear that we wanted to extend that to the broadest possible scope of organisations. So many more people would have got our resources and support and got engaged with the work we did during the pandemic, yes.
Thank you. And so currently, what proportion of the not-for-profit sector do you represent?
I think there's about 20% of the overall care sector is not-for-profit, and in the context of something like care home places, the National Care Forum has about 15% of the overall places. So, I mean, it will vary on a service-by-service basis, but a significant number of those not-for-profit provisions will be within our membership.
Could I ask you just to slow down a little bit,
yes,
please? Thank you. Is it right that in terms of the types of adult social care services that are operated by your members, the majority of them operate nursing homes and or residential care homes?
I think our membership is very diverse, so lots of members. Interestingly, in the not-for-profit sector, lots of organisations will operate multiple types of services. So that's different often to the for-profit sector, where they might just operate care homes or home care. So in the not-for-profit sector, because they have been part of communities often for centuries, if they're charitable organisations, they might do nursing homes, care homes, day services, community services, extra care housing. They might offer all those different types of services within one organisation.
I see, thank you. And I think you have there just covered the range of services that your members provide. In terms of the categories of people that are supported, does that cover older people, people with learning disabilities, physical disabilities, mental health needs, those with dementia and other needs,
yes,
such as
all
addiction?
all adult services.
Thank you.
And some members will provide transition services between children's and adult services as well.
Thank you. Can you just give us an overview of the types of not-for-profit organisations in your membership, please?
Yes, so we'll have charities. We'll have what are called LATCOs, which is local authority trading companies, housing associations, non-shareholding community interest companies, anything. And we have now within our membership some local authority direct provision as well.
When did that come in?
Just very recently.
So before that didn't exist during the pandemic?
No.
And can you just tell us a bit more, please, about the funding and commissioning structures
Of the not-for-profit
of the not-for-profit organisations that are in your membership?
I mean, they operate within the wider care sector, so the commissioning arrangements will be as they are for other care providers. So they'll be commissioned directly by local authorities, or people will pay for their own care if they're self-funders, or they are commissioned by health organisations if they're providing perhaps mental health services, drug and alcohol support services, those types of things. So they have a variety of different funders and commissioners.
Are you able to help us as to what percentage of your members are publicly funded as opposed to?
Probably, well, so if it's working age adults, almost all working age adult services are publicly funded. If it's older people's services, then there will be a mix of provision. So because of the way social care is means tested, if people are providing residential care, for example, they will generally have a mix of people within a home, some whom are directly funded by the state and some who are funded for self-funded. I mean, it would vary from a home-by-home basis.
Thank you. And could I just ask you once more to slow down a little bit?
Apologies.
Because everything you say is being recorded, and it's important that it's recorded accurately. Thank you. Can you help us as to whether there are any structural or operational differences between not-for-profit and for-profit providers that were particularly significant in the context of pandemic response, for example, in relation to resources or relationships with commissioners? So
from the main structural difference is not-for-profit organisations will reinvest any surplus back into the organisations that they're running. So that will go back in either to invest in the care that they're delivering, the building perhaps, or the types of services they're able to offer, or in the staff and the payments to staff. So there's any surplus funding is redirected into the organisation.
And sorry to interrupt, how would that have impacted on pandemic response?
So there have been a number of independent studies that have looked at what the model of how the model of delivery might impact. So I think the inquiry's heard about the Vivaldi study, and that highlighted some better outcomes in not-for-profit provision services. And there was a study called the Fitch study, which looked at the financial impact of COVID in care homes, which reported on better return, better staff experiences during the pandemic in not-for-profit provision in terms of staff satisfaction and well-being.
And just briefly, why do you think that structure led to better outcomes?
I think there are a number of things that are also different in a not-for-profit organisation. One of those is the governance. Often they are governed by local. If they're a local organisation, they will be governed by a board who's made up of local representatives who will be invested in the long-term, ongoing provision of that service to serve that community. And I think they also often come from a perspective of charitable purpose, and their aims and objectives will make it absolutely clear their need to serve their community and ensure ongoing delivery.
Thank you. And as far as the workforce is concerned, are there any distinguishing features that we should be aware of? Again, that would have impacted on the pandemic?
Yes, I mean, we've carried out long-term surveys on pay terms and conditions across the workforce with our members, and generally, when we've compared those against statistics from organisations like Skills for Care, there have been better terms and conditions in some of the services. It's very difficult to say that universally, but that's one of the things that came out through some of those surveys in the past. Some of that was pre-pandemic. Obviously, we weren't in a position to look at the detail during the pandemic, but we continue to look at those operating environments, and we continue to offer extensive support to our members to encourage them to look at things like the sort of funding conditions that were available during the pandemic and encourage them to utilise those for staff in that way.
And to what extent does your workforce include, for example, people who are on 0-hour contracts?
Some of the when we've looked at that pre-pandemic, certainly it wasn't a huge part of the workforce. It's less common generally across the sector in residential than home care, and within our membership there's not huge numbers of home care deliveries. But it's one of the areas that's driven often by commissioning behaviour as well. It's not necessarily a decision made by an employer based on a particular type of employment. It may be driven by the need to commission in that, to employ in that way because of the way they're commissioned to deliver services.
And can you help us as to what percentage or proportion of your members do deliver home care?
I haven't.
It doesn't have to be exact, just to give us an indication.
They'll deliver it as part of their services. So there's no, I don't think there's any of our members who are home care only, so they'll be delivering it alongside other services. If I look at, yeah. So 30% of our members have some home care.
Thank you. And I'll be moving on later to your role during the pandemic, but one of those was advocating on behalf of the sector.
Yeah.
And so when you did that, was it on behalf of both the home care and the care home sector, which are the main areas they're focusing on in this module, or were you focused primarily on care and on residential and nursing homes? So
our advocacy was generally across all of members' services, but we worked very closely with colleagues like the Home Care Association, who had a very specific and unique focus on home care. So where we could add value to that, we did. Where they could benefit from the things we were working on, we did that too. We worked very collaboratively.
Thank you. And we'll be hearing from home care later on in this module. Thank you. Can I ask you briefly about pre-pandemic structure and capacity? The inquiries heard quite a bit about this, but just help us as to whether there were any pre-existing issues which were especially pronounced for not-for-profit providers, and in what ways the pre-existing weaknesses affected the ability of those providers to respond to the pandemic on the ground, please.
I mean, I think there were many pre-existing pressures that have been highlighted by multiple green papers and white papers and a whole variety of commissions, and they've looked at a number of core areas. One is about the lack of funding and investment in the sector. The other is about the lack of focus on the workforce and the lack of workforce strategy and plan. And the other is about the lack of recognition and partnership. These were things that were evident for the not-for-profit sector as well as the wider social care sector. I think in the context of not-for-profit organisations specifically, they were trying very hard often to operate a wide variety of services, as I've talked about. What that means is that they create an organisation model that requires some sort of central contribution from each element of services. And what was happening pre-pandemic was significant constriction in commissioning arrangements. So, for example, many of them would have offered what were described as preventative services, so non-regulated care services, alongside their services that were regulated by the CQC. And there's an interdependency between those services. So if you offer what was called housing support, for example, and you're
Yes.
Then if that's commissioned,
sorry to interrupt, but just focusing on the regulated sector, because that's.
But I think so. I suppose I'm just trying to answer your question, which was about was there anything specific for not-for-profit, and the specific bit was because it was operating both.
Yes.
If you constrict one or you cut the funding off for one set of services, it has an impact on the regulated services.
I see. Thank you very much.
Yeah.
Can I move on then to your role during the pandemic? And as I've said, one of the key things that you did was to advocate on behalf of the sector. Is it right that the two other things that you did were navigating guidance on behalf of your members, supporting them to help them understand what the guidance was and know when changes came in?
Yeah.
And the second thing that you did was engage with the UK government on their behalf. Just briefly dealing with the navigating of guidance first, if I may. Is it right that the National Care Forum issued around 200 briefings during the course of the pandemic? And during the majority of the first wave, those were daily?
Yes.
Just help us, please. Were those briefings delivered by email?
Yes, they would be.
And it's right, isn't it, that at some point during the pandemic you opened up that service much more widely to the sector?
Yes.
Did that include for-profit organisations?
Yes.
So it was to the sector as a whole?
Yes.
And just help us to understand, so how would those organisations have known and have been party to that service? Would they have registered with you and then gone onto the email list, or how would they know about it?
Yes, or it would be cascaded through other organisations they might be part of. So, I mean, we're very enthusiastic about working together. So we're part of something called the Care Provider Alliance that brings together all of the trade bodies that work in the care sector. And we work with lots of local care associations as well. So we shared all that information with whoever wanted it, really. And alongside those emails, we had weekly briefing meetings, which again we included many other people in. We produced lots of resources and made as much as we could freely available to everybody.
Thank you. So the Care Providers Alliance, it's right that is an umbrella organisation, and in fact one that you currently chair?
Yes.
So how many organisations are there?
So there's 10 trade bodies in that.
And is it right that each takes it in turn to chair it?
They do.
For a year at a time?
Yes.
So you weren't the chair
I wasn't.
During the pandemic. And as far as the CPA is concerned, is it right that their reach covers about 95% of the adult social care sector?
Yes.
And so in terms of an organisation that the government, when it comes to future pandemics, may use as a source of distributing information, would you say that they are an appropriate body to work with in that sense?
Yes, absolutely.
In terms of advocacy, you issued over 150 press releases, is that right, during the pandemic, on a wide range of topics, so covering, for example, death data, visiting restrictions and things like that, is that right? And that was often jointly with other representative groups, as you've told us you liked working together. Did you also undertake a range of surveys?
Yes.
Do you know how many of those you undertook?
I couldn't tell you off the top of my head, but I would think it would be around about 30 surveys on different topics, sometimes repeat surveys on the same topic, and we also engaged in lots of research where that was available as well. We stimulated research happening as well and brought members together with academics and other experts to ensure that the best information was available.
Sorry, I don't know if I misheard. Did you say stimulated research?
Yes, so for example, the less COVID research, we worked directly with Leeds University, supported by the Dunhill Medical Trust, to get early understanding of the impact of COVID on older people.
And just could you just explain what stimulated research is? What does that mean?
We talked to researchers and said this is vital that somebody's looking at this. It wasn't being looked at by the government. There was a massive gap in terms of understanding of how COVID impacted older people, what was happening in care homes. And so we have good, strong relationships with universities. And so we were able to work with them at pace to produce some research.
And just briefly, what were the key findings of Less COVID?
So Less COVID was really focused on what the experiences of was within care homes, so that the key kind of learnings were that the way in which COVID manifested for older people was not the way the government was describing symptoms. We were telling the government this, and of course that created a problem when it wasn't possible to access tests unless people were symptomatic in line with the government's version of symptoms. But this Less COVID was showing, and our work with members showed it was very different. It showed that there had been siloed approaches to healthcare, and so people were not able to access healthcare within care settings, and that included the care that was needed for end-of-life care. It sort of laid bare, I think, some of the kind of isolation that care homes had experienced particularly during that first wave.
So very important research.
Very important research.
The inquiry heard earlier in the week that there were some big gaps in the data available,
Yeah.
and the infrastructure was quite lacking when it came to data. With regard to the research and the surveys that you were carrying out, were they covering the sector as a whole, or were they specific to the not-for-profit sector?
So generally our surveys would have been with our members directly. Obviously, probably the one that's we thought was most important to start with was one about the deaths within care homes. We were hearing directly from members of the very huge toll within care homes, and we weren't seeing any of that reflected in government data. So yes, that survey particularly was carried out directly with members, asking them with a week apart what their experience was and what was happening within their homes. And that we published that, I think, on the 19th of April, 10 days before the government produced any data on the deaths within care homes.
And we'll go to that in a moment. But with the surveys, were they collecting quantitative data or qualitative data based on people's experiences, or was it a mix of the two?
It was a mix. If you could ask a question with a number, we did, because we know people love numbers. But we also wanted to capture some of the real life experience of people as well. So it was a mix. And later on, we developed what were called pulse surveys. So we developed those on a monthly basis, which looked at core areas once it became clear what they were. So things like access to PPE, access to testing, visiting, all of the sort of things that were part of the ongoing delivery of care within a pandemic. And we wanted to use those to kind of provide a benchmark to say how things were changing, or how resources were or weren't reaching the front line.
We heard that the Vivaldi surveys were carried out by telephone with the managers of care homes. How are yours carried out? And
usually by email. By
so was it a
online
questionnaire
questionnaires
that
yes.
was distributed, and
Yes.
generally what kind of response rates did you have?
Again, without looking at individual surveys, but we had, we always reflected it as a percentage of the membership, and I think we were generally getting 60-70% of the membership. Excuse me.
And was the data that you were gathering through these surveys purely to assist you and to help you with your advocacy, or was the data sent directly to the government?
It was always sent directly to the government, as well as the advocacy, as part of our advocacy, but also it was, you know, I think, I hope it's reflected in the papers that you've seen. We felt it was very important to keep the government as up to date as possible in terms of both the questions and challenges that were happening, but also to, you know, show them, you know, what the direct experience was of people on the front line.
And was the data that was gathered through the surveys collated in a structured and formalised way?
I mean, we used a tool, probably something like SurveyMonkey, and it was utilised. You know, we pulled it together in that way. So, you know, there would be a variety of, depending on the topic. Sometimes it would be anonymised. Generally, we asked a similar set of questions so we could stratify it. You know, what's the size of your organisation? Because we were aware that different size organisations were impacted differently by different elements. What group of people are you working with? What types of settings are you talking about? So, yes, we definitely tried to represent it in that way. And if it wasn't anonymous, because we wanted to follow up with people, then we would ask them if they would be happy to be followed up with directly. And for sometimes we would ask people if they were happy to be connected directly to government, and sometimes we brought people directly to government as part of a round table, or because they had a particular issue or problem. So particularly when we found an early issue that hadn't been raised before, for example, when it became clear that quite early on in the pandemic, when people were coming up for insurance renewal, for example, and were being told by insurance companies they would no longer provide any public liability insurance, you know, which is a fundamental problem because it's part of a regulatory requirement, we brought those members directly to government officials to say, you need to take this issue seriously.
And how receptive did you find government? And when we say government, are we talking about the DHSC?
Talking about the DHSC primarily. Sometimes we would have gone to other departments, but we sort of saw them as a route through if there was a need to bring in other people.
Did you ever work with any of the scientific advisory groups, the modelling groups, for example, to assist in the response?
I didn't personally, but my colleague Liz Jones was involved in the social care working group.
But in terms of the provision of data, I think she was a member of the group.
Yes.
But in terms of the provision of data, did the government or any of those groups come to the National Care Forum and say, look, we've got these gaps. Are you able to survey your members and collect this individual care home level data for us?
No, not to my recall.
Is that something that you were set up to do, to be able to do during the pandemic?
Well, we weren't set up to do that in that sense, but if there had been an opportunity to do that, I'm pretty sure we'd have grabbed onto it if it was possible to do without significant burden. And I think that is part of the balance, I guess, that we were always aware that if you were going to ask people to do things, then they needed to, you know, you needed to balance that appropriately with what else they were trying to cope with, and also you needed to give them information back. So there was a corporate data collection vehicle, which was a capacity tracker. And so whether those particular scientific questions were being fielded through that, we did sit on some of the groups that looked at the data that was being collected. And I think our big, you know, we're very supportive of the need for a better data infrastructure, but what never came forward in a way that appeared helpful was feeding that data back to the sector itself. So not recognising that actually with that information people could have made active choices to perhaps do things differently or...
We heard earlier in the week how especially when it comes to the domiciliary care sector, there are real difficulties in gathering some of this baseline data. Are there any practical recommendations that you would invite the inquiry to make to deal with some of those difficult issues?
Yeah, I mean, I think that there is a huge amount of data in the care sector which can tell us lots of things about the kind of well-being of individuals, what supports them to to deliver effective care, and so forth. So I think in terms of the recommendations, we need to invest in that data infrastructure. We don't have routinely in care organisations people who hold a role of data analysis, for example. At the beginning of the pandemic, we only had 20% of care providers who had electronic care records. And yet one of the early learnings from the less COVID research was that actually having an electronic care record made it so much more straightforward to understand what was happening to people.
So, has that position improved now? That
position has now improved. So the government did eventually invest in that, but not until April 2022, so after the pandemic. So there was quite a shift in terms of take-up, but that was all care providers investing in that kind of data system for themselves.
Sorry to speak over you. Perhaps focusing more on the domiciliary care sector, and it may be that we need to ask the Home Care Association about this too. But do you have any insights into how we might deal with that tricky issue of gathering data from not just regulated domiciliary care providers, but also unpaid carers?
I don't have in relation to unpaid carers, but for domiciliary care, it's the same. There is the same opportunity in terms of electronic care records, and there is a good take-up of electronic care records now within domiciliary care. I think that there are great opportunities going forward about supporting people to own their own data. So that would be an opportunity for unpaid carers to be able to contribute data that they observe and that they identify in the delivery of their care. And you can see that in some of the initiatives that have happened with things like virtual wards, for example, where people who are looking after somebody in their own home are asked to carry out blood pressure monitoring and things and gather that kind of data. So I think there are ways like that. But I think probably the other side of it is social care data has not been recognised as important because the professional skills and expertise of that sector are not recognised in that way. So we haven't seen it as valuable in the past. And I think, I hope that's one of the sort of the opportunities from the pandemic to recognise that actually that data could tell us, if you wanted to understand how COVID impacted on somebody with dementia, the only people who could really tell you that were people who were working in social care, because they were the people who were looking after and supporting those individuals. And we were not routinely asking those people or enabling them to carry out that data collection in a meaningful way.
Thank you. And do you have any, before we leave this topic, do you have any insights in relation to research in the adult social care sector?
Yes. I mean, there's lots of work we do, ongoing work with academics in the context of research. I mean, I think one of the successes of something like Less COVID and other research that we've been involved in subsequently is having the operational expertise involved at the development of that research. So not creating studies which won't have a material day-to-day impact. And I think the other element is about speed. So the changes in terms of what we want to do with research, generally the priorities are things that need to change quickly. So we need to think about how we can utilise some of the speeding up of research, speeding up of approvals, for example, and things like that happened during COVID, and think about how they can be applied in real time now.
So could a solution be, for example, to have a number of sleeping contracts for specific types of research that could be activated quickly.
Well,
during
and
the
to
pandemic.
create and to think about those sort of bits of the architecture we don't have in social care, like a social care data observatory, that would mean you could regularly feed this in. We have huge amounts of wonderful research of the voices of people in care, which provide great insight and great recognition of the importance of of what people value, and yet because we don't capture that in a sort of central repository, we can't learn from them again and again. And I think we need to think about how we do that.
And who do you say should be responsible for maintaining that sort of repository?
I mean, I think from my perspective, social care is a public service. If we want to improve the public service, then the people who have overall responsibility for the public service, which is the government in the context of the Care Act, should make sure we've got the best available information, expertise, innovation available for those who are going to receive care. That's our commitment, is to deliver the best care for people, to enable them to live the most fulfilling lives. That data, that richness of experience would tell us what that is. And so, if we're going to deliver better public services, let's invest in that.
Okay, but you wouldn't specify a particular...
Well, I would specify that, the government already funds NIH and the National Institute of Health and Care Research. It's that kind of body that I think we should be looking at. The government's looking to fund very significant data platforms, for example. If we can get the social care data from that and draw that into ongoing plans for the development, we're just started a significant reform exercise through Baroness Casey's commission.
Yes.
That's exactly that sort of data should and could inform a commission.
Thank you. I said earlier that we'd go to the deaths press release, but I hope we've covered it. Is it a fair summary to say that in April 2020 you carried out a survey which showed that the number of deaths in care home was much greater than that had been reported, and you say that by the end of April, as a result of that advocacy, the data did start to be properly reported in public?
Yes.
Is that right?
It is. I think what we also did at that time was make really clear the things that needed to happen to prevent it further and support the sector, and those things didn't happen in the way that we talked about. And I mean, there are various things that came along as time progressed, but key issues like the access to community health care, access to expertise and geriatricians coming into care homes or explicitly looking at the experience of care homes was not happening, nor was the sort of testing of everybody within care homes. And I think whether you're going to focus on the discharge experience, but we were relaying what members were telling us. We're not sitting in a body. I'm not sitting in a position claiming clinical expertise in that sense. We were telling them what was actually happening and what members said that they needed to have in order to ensure that the people they were looking after were as safe as possible.
And with that particular issue of geriatricians coming into care homes, did that improve as a result of your advocacy?
It raised the issue. I don't think we saw a direct response in terms of that.
Thank you. The next topic is, in fact, your engagement with the government.
Mm-hmm.
I'm just going to go back in time a bit to January.
Mm-hmm.
So if we could please look at our first document. It's at tab 3 of your bundle if you want to turn it up, Professor. It's INQ 000 532 335. And if we start, please, with page, I think 6, of that document. Can you see there's an email from you on the 24th of January 2020
Yeah.
to various people at the DHSE. And is it right that you were in contact with the DHSE at this early stage?
Yes.
To raise concerns about the potential impact of the pandemic
Yes.
on members? And do you remember what it was specifically that triggered you to take that action?
Members getting in touch with us directly to say, what should we be doing? How should we be protecting staff and people we're working with?
But at that early stage, what was it in particular that was
I think
concerning
people had seen the stories of what was happening in Wuhan and were thinking about how that might have an impact here.
So they were thinking ahead
Yes.
to what preparations they could put in place
Yes.
at that time,
Yes.
so that they would be better prepared for something if it did come along. And in this email, were you asking the DHSE whether the guidance that you had found online, which I think was available for healthcare services,
Yeah.
was the one that you should be advising your members to apply, or whether there was any other guidance or advice that you should be...
I think I was thinking, if people are asking me, I'm kind of hoping that people are asking internally in government, and somebody's busy thinking about how social care should prepare.
Yes. And if we look at page 5, we can see that you received a response that day and in fact replied back saying, I understand, so if we go to the top of the page, so this is after you've had an initial response saying that they would look into it and get back to you. And then you say, yes, I understand we've been connecting across a number of levels. What was that in reference to?
That was because they were saying 2 other colleagues had been in touch with the same questions.
With the same questions. And you say, in fact, I suspect that is reflective of the growing concern amongst providers who've been contacting us individually, wondering if there is any particular action they should be taking. And you go on to say that you'll be able to ensure that the information received gets shared across the CPA and on the website. What was the purpose of you including that in your email?
Why did I say that?
Yes.
Just to be clear that they didn't, because the other colleagues who had connected were from the CPA. So I wanted to be clear that I was going to take that action and that they didn't have to. So it was a sort of message to government and to my colleagues to say,
And was it
we'll
to
do it
say
once.
You can use us as a vehicle to communicate with a
Yeah,
large
I mean,
part of the sector?
yes, partly that too, yeah.
And is it right that you were then told by the government that the guidance that you had sent a link to was indeed the one that you should be
Yes.
directing your members to, and that was the healthcare
Yeah.
specific guidance? And then if we go to page 3, please, we can see that on the 13th of February, it's the page before, please, page 3. You got in contact again on the 13th of February.
Yeah.
And you say there that the reason that you're coming back is to provide some feedback on specific concerns that members have been raising with you when trying to apply that guidance. Is that right? And you then set out a number of key concerns of your members, which included problems with being able to self-isolate, problems with accessing PPE or knowing what PPE they should be accessing. You also highlight workforce issues. And then you say in the penultimate paragraph that it's imperative that you provide some targeted guidance for the sector that picks up on these and other issues. And you explain that it's a very fractured sector and you want to ensure that all those who receive care and support continue to be provided with safe and effective care.
Yeah.
So was this early warning of the issues that in fact ended up being accurate as to the key issues that eventuated in the pandemic?
Yeah. I mean, it's probably one of many emails that we sent through, basically just saying the guidance that was being produced was not adequate. It didn't demonstrate any operational understanding of how social care was delivered on the ground. We may go on to look at it, but
Yes.
when further guidance was developed, which supposedly was accurate or targeted at social care, it continued, I think, to not address the issues that have been raised.
Yes, and we will go
Yeah.
on to that. So just keeping to the chronology, if we can. So you've got in contact end of January, mid-February. You're saying we really need bespoke guidance, and just for completeness with this chain, we can see that on page 2 you're told that there's a small team coordinating central support at DHSC and that they'd get back to you. And then on page 1, is it right that you were saying that you, paraphrasing, it's a very rapidly developing thing that's happening, but you would appreciate, rather than waiting for central guidance, which might take some time, you would prefer to have small bits of advice quickly?
Yeah, I mean, I think that clearly this is written before we knew what some of the challenges of waiting for guidance would look like.
Yes.
Yes, I think that I'm trying to give them some opportunities to get something out that's clear what people should be doing. So you know, if you've got a sector of 18,500 organisations, in my mind, getting 18,500 organisations to work it out for themselves doesn't seem a sensible or efficient way of responding to a crisis. So it was to try and say, if you can't get it perfect, get something that will help people to know what to do right now. And plan. I mean, I think it's all about this. At this stage, it's very much planning. So, you know, if it was going to be, as it then transpired, something that needed larger amounts of PPE or you know, some of the things that it's now clear that the government was talking about behind the scenes, in a sense, if providers had known some of that, then it would have been possible to be better prepared. It might have been, you know, in terms of doing things like thinking about what isolation might look like and how can you build that into your structure in a care home. But that's what we were looking for, some sense of that.
So you were looking for as much advance notice as possible
yes. I mean, that's my job,
the types of things that you might need to put in place. Yeah. And we can see in that email that you say in the third line from the bottom, happy to help. Was that you, again, offering to help?
Yes.
And what did you mean by that? Was that a reference to helping with co-production of guidance? Yeah,
I mean, generally it would be about, you know, either looking at something and giving some feedback or testing it on people or you know, asking people who'd got experience. It's not, you know, it's not that there wouldn't be anybody who didn't have some of the answers perhaps out in the sector that we could have drawn on.
Thank you. And just at the top of that page, we can see that DHSC, in fact, agree with you that getting out what they can to the sector quickly is more useful than hanging around for a blockbuster edition. Yeah. And then if we go to tab 18 in your bundle, which is INQ 4051203, please. And if we start at page 6, and again working backwards, we can see that on the 19th of February 2020, that a draft, is it right, this is a draft of the guidance that eventually came out on the 25th of February?
Yes.
So a draft is sent to you and others, attaching, in an email, and we can see that you received that at 1:54 hours on the 19th of February, and in the email itself they're saying that the deadline for reply is lunchtime tomorrow. Yes. So it would be helpful to have returns by 12 at the latest. So you had less than a day to respond, and was that sufficient for you to be able to meaningfully input and respond to that draft guidance, do you think?
No. I mean, clearly, patently not if I'm going to do something directly with providers. I mean, as we had already started to raise issues and discussions, I mean, we did respond and gave lots of detailed feedback around it. But I think it's yeah. I mean, I think if this is about getting people prepared and in the right space, then we felt that something that absolutely talked to people in the settings and environments that they were working in was going to be crucial. If you get a bunch of stuff that doesn't relate to your experience, then all you've got to do is reinterpret that and try and understand it and fit it into the space that you're in. So yeah, I mean, more time would have been helpful. Clarity, you know, think at this stage, setting up, you know, working groups that could do this. This was sent to me. I've no doubt it was sent to a variety of other people as well to comment as well.
Yes.
No inducement for us to work together or to. So where we're trying to do some of that as much as we can, and I've done that.
Yes.
Through a tried and tested mechanism of copying in multiple people to show them what our thoughts were so they could respond rather than getting them to do it themselves.
The reason I asked is because I think you and also a number of other people in their evidence talk about the lack of time that they had.
Yes.
To respond to draft guidance, for example.
Yeah.
But is it a fair summary of what you said, that you've got to balance things and you appreciated that on the one hand there was a need to get things out quickly to the sector, so although ideally you would have had more time, actually you appreciate that this was a fast-moving situation, and so...
Yeah, I think it's a fast-moving situation. It's a situation where lots of people are just beginning to think about it as well.
Yes.
But I suppose the point would be that at this stage you could have set up something more meaningful to focus on guidance on an ongoing basis that would mean you didn't get yourself in this mess time and time again, because this was a repeated pattern of less than 24 hours to respond to anything, a repeated pattern of asking multiple people without being clear who's been asked, so then as a government getting multiple responses which they were trying to balance. There wasn't a weighting, I understood, that was attached to operational reality versus clinical guidance, for example.
Yes. So is it the case that you're saying that groups that are co-producing guidance and policy should be set up right at the start of an emergency, whereas what in fact happened was that you were being sent almost finalised versions of guidance and not given an opportunity to shape that guidance? Yeah.
Well, I think often
at
this early stage we were getting guidance that had and social care added in behind health. I mean, that's as bespoke as it felt.
Thank you. And if we look at page 4 of this chain, we can see that, just summarising, you say that the information is helpful, and in the second paragraph you say, however, I think that the advice whilst talking about the care sector does not feel like bespoke guidance, that will reflect the reality of someone in either a home care or residential setting. And you go on to say that there are some really practical challenges that you think the guidance either needs to recognise or better still address.
Yes.
And then you go on, don't you, to set those out.
Yeah.
And again, just summarising, you talk about older people who are living with dementia or very profound learning disabilities, and the practical difficulties they would have, for example, with face masks or self-isolation.
Yeah.
You talk about the storage of waste and how guidance that would be given to hospitals where there would be special areas to store waste would not apply to someone, for example, with incontinence pads building up in their own home where they've got no other space. You talk about laundry in the same context. And you go on to explain, quite importantly, that personal care, in fact, involves care workers being in very close contact.
Closer than 2 metres, yes.
And therefore the advice that was being given that people should avoid being within 2 metres didn't really apply. And then you go on to talk about self-isolation again. And then you say that you would recommend that before the guidance is published, that you're given an opportunity to have a second review of that guidance. Did that happen?
I don't know, to be honest with you. It came out a few days later, so quite possibly not.
Thank you. And then on page 5, we can see in the last main paragraph that you say that there's a wide range of other issues that you know have been discussed, and that relates to issues that you'd already raised in January and February in relation to things like workforce, PPE supplies, and additional costs. Is that right?
Yes.
Of the equipment that was being required.
Equipment, working in different ways, trying to support people who are being isolated. You know.
Thank you. And just for completeness again, if we look at page 2, we can see that other people who were copied in, so at the bottom of the page, that's the Care Quality Commission responding to your email saying that they had nothing to add beyond what you had raised. They agreed that it wasn't particularly tailored to the adult social care context, and they encouraged the taking up of the offer of working with the Care Provider Alliance to make sure that the guidance landed well and didn't create a high volume of follow-up questions and feedback that they had no plan for addressing. So the position is that they're saying actually this is going to save you work if you put the work in now. And on page 1, we can see, in between there's also a response from the Director of Association for Real Change, and then on page 1 there's also a response from the government saying that you made some good points, but also raising the fact that social care is also provided a great deal by unpaid carers and personal assistants, and it would be helpful to have that reflected in the guidance. So that's someone within the government raising that in February. And did the guidance in February that was issued on the 25th include all of those points?
I don't think it did, but I haven't got that, the detail of that.
If we look at, please, INQ 4049574.
Do you know what tab that is?
Yes, I'm sorry, I didn't make a note of this one. I'm just trying to look it up now. I think it's tab 17. And I'm not going to go into the details of this, but just to have a quick look, we can see that this is a meeting on the 10th of March. It's a meeting between Liz Jones, who's your policy director, and 53 members.
Yeah.
And we can see that the purpose of that, if we look at the session aims, is to support members, but also in the 4th paragraph, we can see that what's noted there, that it's important to try to engage, to try to ensure government does not make incorrect assumptions about how local areas are responding, and the ability of providers to respond on their own without coordination and support across local authorities, local health systems and supply chains. And was the plan to feed back these concerns to the government, I think at this stage through the National Steering Group? Yes.
So there were various iterations of early groups, and the National Steering Group may have been one iteration of that. But
yes. Yeah. Thank you. And sorry to rush you, but I just want to deal with this quite quickly, because we will be moving on to the various groups that were set up. But on the 10th of March, is it right that you were raising similar concerns again? But in addition, at this point, you were also raising the concern that actually it wasn't something that could be coordinated locally, and that there were concerns about the response that had been received so far locally from local resilience forums, the NHS, and community healthcare.
Yes.
And so was this on the 10th of March, the National Care Forum really saying to the government, we need central leadership and coordination?
Yeah, I mean, I think there were part of the challenge throughout the pandemic, to be honest, was about the relationship between national regional and local systems, and indeed between different parts of national government. So, for example, in areas like guidance, we had number of different bodies making guidance. So, Public Health making guidance, NHS England making guidance, the HSC making guidance, which all interrelated. And then what happened is that went out to local systems, and sometimes it said things like, you know, the local director of public health will make a decision in relation to this. So then there was another layer of decision making and direction that providers had to experience. I think that early on it was obvious that there did need to be some national steerage of it, but the sort of those inconsistencies between who held decision-making powers that were evident from the 10th of March and earlier, to be honest, onwards, continued throughout the pandemic, actually.
Thank you. I don't think we need to go to them, but is it right that one of the issues that you had to repeatedly raise similar concerns about was in relation to PPE?
Yes.
You have exhibited, for example, communications, I think, from Liz Jones on the 1st of April 2020 and again on the 7th of April 2020, raising concerns about guidance and in particular the sector-specific PPE guidance that was issued.
Yes, so that guidance was issued with, that was the first, on the 2nd of April, that was the first kind of bespoke PPE guidance, but it wasn't, it didn't feel bespoke, it referred, it tried to compare domiciliary care, sessions with ward rounds. It talked about, it very clearly was based around a model where people who were receiving care, which really meant health care in that context, stayed in bed all the time and didn't move anywhere. It was just inappropriate. And it talked about bits of PPE which really were not part of the common usage in the care sector. So particularly around visors and goggles, which hadn't been, it's not a day-to-day part of the delivery of social care.
So that stemmed from, you say, a misunderstanding.
I think, yeah, I mean, it just
over-clinicalisation of.
Well, I think if that was what people needed to wear and use, that's, you know, don't think anybody was disputing the kind of clinical expertise. It was more about if this is a piece of guidance that's supposed to give clarity to people who are delivering social care so that they're confident that they're supporting their staff appropriately and supporting people who deliver care and support, then it had to talk to the experience that they were living. So it was so confusing. We had so many questions about it, and that was on the 2nd of April. Then on the 12th of April,
yes,
they moved to a position of sustained transmission, which required people to shift gear again to another level of PPE, and that was so poorly communicated to the sector.
Is the example that you give in your statement where there's a small
phrase that says we're now in sustained transmission. Look at table 4.
Yes.
You know, it would, and so that meant again that people, you know, were trying desperately. I think that was one of the, you know, very difficult times over an Easter weekend or something. You know, it was one of those periods where people were trying to get hold of PPE. We spent all of our time trying to support members to connect up with local resource resilience forums, access PPE in other ways, trying to and raising those directly with the government centrally, but also working with colleagues in local government and the Association of Directors of Adult Social Services to sort of see if there are ways we could, you know, ensure people understood what they needed to do, but also got the resources they needed.
And just to summarise, Professor, on the 1st of April, this is one of the emails, we don't need to go to it, but it's one of the emails that was sent to DHSC about PPE. And in that email, there's a reference to what's called the cycle of doom.
Yes.
Is that right? And,
Yeah.
and that's a reference to care providers feeding back that they were contacting the PPE helpline. The helpline then said, no, either you've had a delivery or you need to talk to your usual suppliers. The usual suppliers would then say, oh no, the NHS have requisitioned all the supplies, you need to speak to them. And then the NHS supply chain would say, no, you need to go to the PPE helpline.
Yes.
And so that's what was,
It was the
called
PPE
the
cycle of doom. Yes. And it was...
in addition to raising issues about wrong PPE being delivered, poor quality PPE being delivered, the rising costs of PPE, and also inconsistent advice about PPE being given by different people.
Yeah, and hugely escalating costs of PPE. I think that's really important to understand. Things that people, were routinely buying, in small quantities, they were now having to buy in huge quantities, and the price had gone up, 100% or more, and there was not funding or support for that.
Thank you. And is it right that the PPE guidance also made the incorrect assumption that care providers, in fact, had a stock of PPE, but you say in your statement that actually the use of PPE within the sector was pretty limited before the pandemic?
So people would have had PPE for instances where they needed to do sort of barrier nursing, or, if there was an outbreak of something like norovirus or that, but it's not routinely used for many of the issues we've raised. So if you have a face mask on, for example, that's very difficult to communicate with somebody with a hearing loss or with dementia who's reliant on sort of facial recognition signals, etc. And it's not part of the kind of clinical guidance in those settings.
Rayner, forgive my interrupting. Did you hear Mr. Hancock suggesting that
Yes.
care homes should have a month's supply of PPE? Have you got a comment on that?
Well, his sort of assumption that having that in preparation for a pandemic and the volume of PPE that people were using did not seem to be particularly practical. And there are many other practical recommendations, like, for example, allowing care providers to purchase through the NHS PPE procurement channels, or indeed providing free PPE right from the start at the beginning of a pandemic so that people don't have to rely on that. Of course, providers, they will have some stock available because they need to be prepared for outbreaks of, or a requirement to do that. But yeah, the idea that they have got a month's worth of supply, if they want, this is a broader discussion about what we want providers to do. And actually, if on the 24th of January, there had been an engagement with the sector to say, OK, this is what we think is going to happen. Let's help you get the PPE you need. Let's help you think about what isolation might look like. Let's help you think about the fact you might not be able to move staff. That would be a very different situation.
Thank you.
You talked about the National Steering Group earlier, and is it right that did start meeting fairly early on in the pandemic? But what you say about that in your statement is that the early meetings were ad hoc and uncoordinated. And it wasn't, I think, until the summer of 2020 that the processes became more structured.
Yes. So there were lots of little groups that met about particular topics, and then that all got sort of brought together. But the very early groups were really, meeting with sort of a peer with very short notice, and as far as I'm aware, I don't think we've got particular minutes from those meetings or anything. They were more of a kind of, what's the latest situation?
Did you find them helpful forums for being able to input and pass on the concerns?
I certainly passed on the concerns. I think it's less obvious what happened as an immediate result of that.
And what access did you have through those early forums to decision makers?
I mean, I think we had one of the reflections, I think, in the email you've just shown is that it was a small team in DHSC. So there was a relatively small team focused on social care pre-pandemic. So we had, we did have connection with the director at the time, and soon to be the Director General and others. So yes, there wasn't a barrier that was put in the way of that. And similarly with the Minister, when Helen Whately came into the ministerial role, that the department encouraged connection with her.
And it's right, isn't it, that you say that those small groups were constantly merging and changing?
Yeah.
Did you think that was a necessary response to the rapidly evolving situation, or did it lead to any overlap, any duplication of work, or groups working in silos?
I think there was definitely some silo working. So often we as an organisation, we're not a big organisation in any stretch of the imagination, and certainly we've tried to go to as many of those meetings as possible, and we often found that we were in those meetings pointing out what the other meetings were talking about. So, trying to connect the workforce meeting, for example, with the discussion around PPE, with the discussion around testing. So there was definitely a need for more coordination in that sense.
And did the same principle apply with guidance
Yes.
writing, that there were various different teams doing the guidance? I think you alluded to that earlier. But
Yes.
did that lead to a lack of coordination?
Yeah, and I think the team that we might have had more opportunity to influence was DHSC when they were writing guidance. We had very little ability to influence PHE or NHS England, where they were writing guidance that was relevant to the social care sector, which lots of it was, but we relied on DHSC colleagues to do that, and I don't know how straightforward that was for them to influence it.
I think in your statement you say that your engagement with PHE improved over time, but they were involved in drafting some of the guidance in February, so quite early on. You say in your statement that DHSE had limited understanding of how adult social care was provided in practice and on the ground. Is that something that you also say applies to PHE or not? Yes.
I would say that. So we had some good engagement with individuals in PHE, and hugely grateful to them for the time that they gave to that. But I think it's only relatively recently, in the reformation of UKHSA, that there's a specific social care team now within that body. So that will have a better understanding of the environment in which PHE public health advice has to operate within.
Thank you. And you said earlier that all of these small groups eventually came together, and you were part of the task force, weren't you, led by Mr. Pearson?
Yes.
As far as thinking about the future is concerned, would you say that the membership and the structure of that body is the type of thing that should be replicated again in future? Or do you have any concerns, for example, about any voices that were missing from that group or anything else?
So the task force then split into a number of different subgroups. So yes. I co-chaired the workforce task force side of it, and we came up with a range of short and immediate and short-term actions. I think the problem with that is that they were not implemented. Largely, they were not implemented. They were they were based on the experience of trade unions, of other workforce representatives, of employers, including people who employ their own assistants. They represented a broad cohort of stakeholder voices. I think the difficulty is that the recommendations didn't manifest. So there is a real challenge about setting up that kind of body, yeah, and then not delivering on what it's suggesting. I think
there's no point having a body recommending things if they're not going to be implemented.
No, and I mean, and some of those things, I think, for example, in that context, were about sort of the occupational health and well-being of staff, a crucial concern for employers, a crucial concern for people across the sector, and recommendations about occupational well-being schemes and things that, that could relatively easily have been operationalised and weren't.
Yes, and we have, in fact, your reports from that subgroup,
yes.
And the inquiries read those. But as far as the structure of those groups are concerned, would you say that they did allow you to meaningfully engage at that time? Well,
it depends whether engagement leads to something, but they certainly allowed us to express a set of perspectives.
You talked about there now being an adult social care team. Just before we end this topic, are there any other specific recommendations that you would invite to help with improving the understanding of decision makers and people who are drafting guidance when it comes to the realities of adult social care operation on the ground?
Yeah, I mean, I think that they shouldn't, those kind of decision-making groups shouldn't exist without the experience of the operational experience of both people delivering care and support and people receiving care and support. I mean, I think you can see that in all sorts of decisions that were made, that they would have been much better able to be implemented if they had had that operational experience right from the start. And I think that is there's an underpinning message there about recognising the professionalism and expertise within the sector, that when there are, I mean, I was listening carefully to Mr. Hancock's evidence yesterday when he was talking about social care representation being him and his minister. We are still in a position where the sort of leadership and expertise of social care is not properly recognised and built in, and I think that having that as a legacy of the pandemic would be really valuable to have that built in.
You say the voice should come from the sector?
Yes.
Yes, thank you. My lady, would that be a convenient time?
I hope you were warned that we were going to go over lunch. I'm sorry, I usually try to finish a witness, but I've got to be considerate of the stenographer who had quite a tough day yesterday.
Mm-hmm. Yes.
So I shall return at 1:45.
Thank you, my lady. Can I ask you on a very brief topic, when did the National Care Forum first become aware of the possibility that patients being discharged from hospital would be discharged to care settings?
I don't know exactly when we were involved in some of the discussions about it. I obviously know the dates when the various bits of guidance came out. There may well have been discussions previously at the national group about it and about the implications of that, and some of the things that we would have certainly been advocating needed to be put in place before that was possible.
But you think it was ahead of the guidance?
I think it would have been part of a discussion, yes, but not in a kind of I'm sure there would have been discussions because that was part of that. Yeah.
Can you say whether it would have been as early as February or not?
I don't recall.
Okay. Do you think if you had early notice of that possibility, that there would have been any practical measures that your members could have put in place? And what do you think those would have been?
I mean, I think when there were, some of the things we produced something post the guidance and post the discharge, which was something that was framed as sort of tips for providers about hospital discharge, and that included the sort of things that they should be advocating for and that were necessary about, having sufficient PPE for somebody during the period of isolation, obviously testing prior to discharge, having access to the correct clinical and community health support that people might need, and ensuring that people's ongoing health needs, because I think that's a really important part of the whole discharge discussion, is that people were clinically fit in the sense they didn't need hospital treatment, but it didn't mean they didn't need ongoing health treatment. In fact, most people within care settings have some generally fairly significant ongoing health requirements. Sorry, in care settings have that.
Thank you. Last main topic, it's on ventilation, please.
Okay.
Is it right that in April 2020 you had an expert called Eric Fuster come and do a report, I think, following which he produced some materials on ventilation? And if you want to turn it up, Professor, it's tab 11, his report in your bundle. I don't think we need to bring it up on screen.
Yeah.
But just to summarise, is it right that he advised that it was important to understand that natural ventilation, for example, opening doors and windows, may not provide the ventilation rate required to significantly reduce airborne transmission risk, even in the summer?
Yes, that's part of his report, yeah.
He went on to say that when windows are closed in a shared communal airspace, the only reliable way of reducing the risk of airborne transmission is to install a mechanical system of some sort. This could be a ventilation system that brings in fresh air to the room and extracts stale air, and or a recirculating HEPA air filtration system.
Yeah.
And he went on to say that if such a system wasn't available, then even if it was winter, you would still have to open the doors and the windows.
Yeah. I mean, I think we engaged the Eric Fuster because he was demonstrating some expertise in this area, and members were concerned about what was happening. I suppose the point that this talks to as well is that the care settings that people operate within, care homes, are very, very different across the country. There's some, old stately home care homes. There's very small purpose-built homes. There's ones which allow for cohorting and zoning and all sorts of different things. They're not a universal approach. And so what we thought, by bringing Dr. Fuster and his expertise in, he could talk to members to help them to work through what to do. I think we're obviously not going to get a chance to talk about all the different funding that came through, the very kind of sporadic funding that came from government, but that it is of note that it wasn't till the very last infection control fund that there was any funding that providers could possibly use for this very area of CO2 monitoring or HEPA filters. So any action that providers took prior to that, and that last tranche of funding, I think, was towards the end of 2021, was done by themselves with their own intent. It wasn't supported by government in any way to do that. So,
and he advises, in terms of long-term strategy, that there are whole building improvements that could be made. Yep. But he acknowledged during the pandemic that those weren't realistic in the short term. Yep. And so he advised things like PPE and good infection control measures to be put in place. Do you know what the position is now, Professor? Do you know if any changes have been made in, for example, any building regulations or anything like that in relation to ventilation? And are there any practical recommendations that you would invite the inquiry to think about when it comes to ventilation of care home buildings?
Yeah, so I'm not aware of any changes that have been made in relation to ventilation or in the building regulations in relation to that. There have been some made in recent years in relation to fire, but not in particularly in relation to ventilation. I think that there are, definitely action that could be taken in terms of thinking about how, back to my sort of central tenet, I guess, that social care is a public service, and if you want the service to be delivered in a safe way, you have to think about what the state's role is in that. So there are many other examples of other types of services where the state has made a kind of significant investment in the built environment, like homelessness and housing services. And so if we're to look towards a different model going forward in the future of a built environment, then I think that there's clearly an opportunity for the government to think about how it invests in that in a meaningful way. Much of the stock, I think there's sort of some recent survey by Knight Frank talked about that much of the stock being over 40 years old. So it isn't that there's a lot of new purpose-built provision in the environment. So if you want to retrofit filtration, or if you want to create an environment where future build has that in place, we need to have some clear direction and some support to deliver that.
Thank you. Could we move on to something a bit more positive? So is it right that National Care Forum produced an e-book called Caring in COVID?
Yes.
And can you just tell us briefly what that was, please?
Yes. So we produced the Caring in COVID book. It's a collection of stories primarily from the first wave of the pandemic, which is showcasing the kind of activities that members of ours did during the pandemic, and it's across a variety of themes. So there's a strong focus around visiting and how people supported people to stay connected with their relatives and loved ones. There's a focus on the kind of things that staff did in order to ensure people remained safe. Some very heartrending stories of people who went and lived in greenhouses in their gardens so they didn't come near their families, or stayed within care settings, people who worked to support the broader community, so potentially they thought about how they could engage, and people who were supported by the community too. And I think it's really important that there's a recognition that, whilst maybe there wasn't as much national attention from a perspective of on what care was there to do, local communities really recognised some of that and were very supportive and helpful. So it's a great collection of that, and we wanted to have a record of that, because we knew that as time went on, it's an incredibly painful period to talk about, but people are amazing, and we wanted to celebrate some of that.
Thank you. And just to take one example, the inquiry heard in the impact film that there were some people, for example, with learning disabilities who couldn't read or write, and so they were very much reliant on human contact. And I think one of the stories in the ebook talks about one particular individual who was struggling with the lack of contact. And when they introduced the virtual contact, social contact, there's a record of that particular individual kissing the iPad.
Screen, yeah, and I think this is, I suppose that was the other point, is to actually just, and you would expect me to do this from my position, but I was completely overwhelmed by how creative and positive and responsive people were to try to make things better for everybody. So again, that level of, you're going from a scenario where only 20% of organisations had digital care records. There was low levels of digital literacy within the care sector. There was often poor Wi-Fi and challenges in that context. And people invested in all of those things. They brought in iPads, they brought new technology, they fashioned pods, they created garden environments to allow people to have as much interaction and connection as possible. And I think that's an important part of the story as well.
Thank you. And finally, Professor, are there any other recommendations that you would like to discuss today?
Yes, yes, there are. I think there's an overall recommendation which is about the urgent need for reform of the sector. We've had multiple papers, policy positions, etc., looking at this. We went into it
Yes,
in a very difficult position. 5 years later, we're still
Yes.
in a very difficult position. So I think there's things about workforce, absolutely, a workforce strategy that properly recognises the skills and expertise and the new skills and expertise we want those workers to deliver in the future, and obviously the funding that goes with that. We've talked a lot about data, digital and buildings. Those all we need to look at what that is to be fit for the future and have a kind of strategic plan to develop that. And finally, something about a kind of, recognising the professional kind of expertise of the social care sector as equal partners when decisions are being made. And that's at a local level, a regional level and a national level. I suppose my sort of ultimate message is that we need those decision makers to think about social care first. It's not Cinderella, it's not the handmaiden of the NHS. It's a vital public service that's the backbone of communities, and we forgot that then, and we must never do that again.
Thank you very much. My lady, those are all my questions.
Thank you, Ms Young. Mr Weatherby, just there.
Thank you very much, and good afternoon, Professor. I ask questions on behalf of the OBE Families for Justice UK, and I have just one topic and a few questions. It's an important topic. It's DNA CPRs, which, as you'll appreciate, is a very traumatic topic for quite a number of the families I represent. On the 26th of March 2020, you emailed Ros Rawton, who was then the DHSC Director of Adult Social Care, following contact from one of your care providers. And I wonder whether we can just put the email thread up. It's INQ 466452, and I think it's your tab 18.
Thank you.
It's up on screen now. Can we have page 3, please? So 26th of March. And you're sending this, as I say, to Rosamond Rawton. Mm-hmm. And you say that, Ros, we've been contacted by a care home provider in relation to a flurry of emails and letters from their local GPs, essentially requesting that all residents in the home are put onto a DNAR. In one of the emails, which I know is not the scanned copy, there is even a suggestion that the GP is following government guidance stating that all over 70s in homes should be issued with a DNAR. This is a very urgent situation that could escalate very quickly and unhelpfully, causing lots of fear and concern amongst residents and their families, made worse by the fact that people are being asked to make decisions about their family members who they may not even be able to see for the last couple of weeks, nor do they have any prospect of seeing. I'd like clarification ASAP if this is in any way endorsed government policy. And then it goes on. I won't read it all. And then finally, I'd be grateful if you could also let me know the response. I think these things are probably happening all over the country. You then sent later the same day, in fact, going up to page 1 of that thread, please, the bottom half, to the same, well, to a CQC person, but also copied to Rosamond Rawton. Sorry, I've lost my reference. Just give me a moment. Sorry, you sent another email in the afternoon, bottom of page 1.
Yeah.
Further letters come through on this issue, headed sample of GP letters. The penultimate paragraph says this, quote, "We will also be signing forms to say that if your heart or breathing stops, the carers will not resuscitate you. There will not be ambulances available to continue any resuscitation or take you to hospital, so that will not work. You would be unconscious quickly and not be aware that this is happening to you, and not be in any pain, unquote. The homes are being asked to give this letter out to all residents in the care home. Apart from this being extraordinarily upsetting letter for people to deliver to already vulnerable and anxious residents and families, it is essentially telling people that they will be left to die. Where was the decision to ration resources in this way made? And then you continue in terms of community health and the CQC. Just two points arising from that. Your emails suggest that there were multiple GP practices involved. Are you able to help us in how widespread you understand this issue was at the time?
So on that day that we had received note that there was a flurry of emails. Yes. So that was the description. That I couldn't quantify that anymore, but I was aware from talking with other colleagues in other organisations like my own that they were also aware that other groups of people had received. Yeah, so not an outlier. But a flurry. It was. I think it was an early, a bit like I was describing earlier, an early indication of something that we wanted to stop before it got more. But it was not. This definitely not the suggestion. It was one letter alone. No, indeed. And you say, as I've just read out, I think these things are probably happening all over the country. And is that because the accounts you're receiving were coming from different areas? So the provider I was talking about was a national provider, so they were reporting it was from different parts of the country. Yes, thank you. To your knowledge, who was instructing, if anybody, who was instructing GP practices to put DNA CPR notices such as this in place? I never had any answer to whether there was any instruction around that. And in fact, what happened as a result of this is we quickly did work with the Care Quality Commission and the BMA and I can't remember who else was signatures, but we put together a statement. Yes. That's my last point. I'm going to take you to that if I may. It's I think it's your tab 19. It's INQ 398629, and it's page 7. So, as you say, within a very short period of time, this is the 31st of March, you and others, and you say the RCGP, the BMA, and the CQC got together a joint statement. It's set out there in your email. And I won't read it all out, but it sets out in very clear terms the importance of having personalised care plans in place, particularly for people who are elderly, frail, or have other serious conditions. And it sets out what we've heard over and over again in this inquiry about the importance of the person themselves, if they have capacity, or the family, and them being individually put forward. And it finishes, it's unacceptable for advanced care plans with or without DNAR forms completion to be applied to groups of patients of any description. And I think, again, we won't go through the thread, but on that thread there was some discussion about whether it should be made even tougher, that joint statement. But that was put out in an attempt to bring an end to what was apparently that in the end, that was we were happy to go forward on the basis of expediency. And knowing what you know, was the statement, in your view, strong enough? I think that was the last time I heard of that situation. So and I think it's a very good example of that. But it also, I think, is the mechanism from my memory was that the surgery had sent this to the care home and asked the staff to deliver that message. Based bearing in mind this is potentially against people who've only just been discharged into the care of that home where they have no relationship with the relatives. So I think the impossibility of the task and the inappropriateness of it combined was our urgent need to act.
So you, as an organisation, identified the problem, brought it to government's attention, got together a consortium of people to put forward a strong statement in an attempt to do something to stop it. Do you think there's a risk of a similar practice happening in the future, and what needs to be done now in terms of avoiding it if that's the case?
I mean, I think that I suppose I've mentioned about the sort of need to have social care as part of decision making. So I think this is in. I suppose we read this as a kind of clinical response to a situation rather than a response that focused on people, and that's, I think, where social care can add huge amounts of value. So I think having we talk a lot about an integrated health and care system, but often that means an integrated health system delivering to care, and I think going forward, and we've just got the 10-year plan launched today, we'll be looking at that very closely to see if it actually means meaningful integration. So that will be one bit of it. And I think the other the other way going forward is to have a much, there's an ambition for a shared care record. I think very clearly having a care record that moves, when people move, goes with them, would mean that their sort of wants for themselves or their guardians' wants for themselves are clearly articulated and cannot be overridden without permission.
And finally, we heard yesterday the suggestion that there were various rumours during the pandemic about things which may or may not have happened. In respect of this problem, DNA CPR, you're clear, I think, certainly from this correspondence, that there were blanket decisions being made, at least at that point.
Yes.
Thank you very much, Professor. Thank you.
Thank you, Mr. Weatherby. Ms. Fubster, who's over that way.
Thank you, my lady. Good afternoon, Professor Rayner. I represent John's campaign, the Patients Association and Care Rights UK. At paragraph 6 of your witness statement, you explain changes to the CQC regulatory inspection regime during the pandemic. And you highlight some concerns, including, first, that the regulator was slow to act on serious concerns about clinical practice and decisions relating to social care. Second, the suspension of on-site inspections. And third, the move to a risk-based model for inspection and regulation. And you also explained that outdated ratings caused issues for providers accessing insurance cover and in securing public sector contracts at crucial points in the pandemic, and in many cases are still causing issues. Do you agree that proper regulatory oversight should have continued during the pandemic? And if so, what more should the CQC have done?
Yes, I think that the points that you've raised were absolutely the things that we were concerned about. I think in the context of what proper regulatory oversight would look like did need to change, probably because of the prevalence of on-site inspections. I think our experience of working nationally with the CQC was different to the local experience of providers. So some providers would talk positively about their relationship, their ongoing engagement with their local inspector, and that was helpful for them. It wasn't universal, it wasn't across the board, but that was helpful for them. I think nationally we saw that there was probably more that could have been done to identify, utilise their data, for example, to identify trends and issues, and to be more public about some of those challenges that they were seeing. There were lots of, we knew that there were lots of data coming through which talked about any breaches or anything like that. So a bit more sort of oversight of that and bringing that forward would be helpful. I think there's a very large support from the provider sector about what good regulation is. I think you're right to say that we believe that there's challenges continuing and ongoing, and we certainly, in part of my role in the Care Provider Alliance, have been focused in on reviewing the CQC and the changes in regulatory regime it's made subsequent to the pandemic.
And visitor restrictions removed other eyes and ears, which played a role in ensuring good quality care and identifying inadequate care during the pandemic, including not just family members, but also visiting professionals like GPs. How did that impact on the rights of people who live in care homes, including to access the healthcare they needed?
So I think we were very active working with colleagues in John's campaign and other organisations around visiting restrictions to try and do as much as possible to bring more visitors back into services, and equally trying to ensure there was better access for community health services and access to physios and others. I believe that we need to do much more going forward to balance those risks that were identified in the pandemic. So we spent a lot of time kind of measuring those markers of infection, but not looking as much at the kind of markers of isolation and loneliness, and getting that balance right from a human rights perspective. So I think that the absence of visitors and the absence of visiting professionals changed the dynamic of a home, absolutely. And I think that is things that, I hope people feel that once restrictions were lifted, there's been a welcoming back in of both people and those professionals.
Do you agree that the CQC should have a duty to monitor compliance with legal duties, including human rights and equality legislation and guidance, including on visiting and risk assessments?
Well, the CQC, my understanding is the CQC framework is built around a human rights framework, so it does have a strong focus on human rights within it. I think in the context of the regulations that have been introduced since the pandemic around visiting, I think that it's an important part. It's back to what are we going to value, and if we need to make sure that if the regulator is looking at areas like visiting, we're also at the same time capturing why that's important, so that when or if another pandemic comes that puts at risk roles like essential caregivers, we've got the evidence there to demonstrate not just that people have complied with allowing visitors in or whatever the detailed regulation, but that actually we are really clear what difference that makes to the ongoing well-being of people. We've got the data, we've got the information, we can evidence it, and we can show how somebody's well-being is impacted by not having visiting, and so we don't have to have, we don't lose that relationship as swiftly and rapidly and for as long as we did during the pandemic.
And final question, at paragraph 3.2H of your witness statement, you refer to Care Act easements. What was the impact of these Care Act easements on people needing care?
3.2
H.
Sorry, I'm struggling. Can you say me?
Sure, 3.2.
It's just the question is,
yeah.
you refer to Care Act easements. What was the impact of the easements on people needing care? Can you deal with that general term?
Yes, of course, yeah. So the impact, I think part of the easements were something that we, obviously monitored where easements were happening in different parts of the country. But I think that the part of the reality of the squeezes and the decades of kind of austerity prior to the pandemic meant that the overall implementation of the Care Act as a whole has not been fully achieved in lots of parts of the country. So the impact of bringing in easements at that point will have exacerbated for some groups of people the challenges that they were facing already. I think in terms of sort of lack of access to assessments and those other areas, we're in a scenario where currently we have long backlogs of people accessing assessments. I think it's part and parcel of an overall lack of value of the importance of social care to people in terms of living the fulfilling lives that they need to have, and the willingness to sort of bring in easements rather than perhaps some of the other changes that might have properly funded, for example, people's ability to isolate or buy in HEPA filtration or whatever. I think it is, there's a story that needs to change about how people's care is valued at both a national level and in the public's perception.
Thank you,
Thank you,
Professor
Ms.
Rayner, my lady.
Professor, that completes the questions we have for you. And please don't worry if we haven't covered something in detail. I will obviously make sure that I read your written statement very carefully. And of course, have an opportunity to make some closing submissions at some stage. I don't know if that'll be you again, but wherever you are, be you in the witness box or over there, you are an excellent advocate for an excellent cause. Thank you very much.
Thank you very much.